air will rush in, air will go into the trachea, into the bronchi, bronchioles, etc. And each alveolus, and remember millions of them are there. So each alveoli, I should say not alveolus, each alveoli will get filled up with air. Remember, before I go ahead, there is already air inside each alveoli, right? That is called dead cyst air. Once we breathe, after we are born, right, air goes in and air remains in the lung and air remains in each alveoli. So air is existing in each alveoli. So when I give you an example of a balloon, which is at the end of a stick, right? There is a balloon like this. This is a stick. There is a balloon like this. In this balloon, there is already little air. It is not flat. It's not deflated. There is already some air in it. Now, if I blow more air into this, then this balloon will become bigger. When I stop blowing air into it, what will happen? The extra air which I have put under pressure. When I blow, I'm using pressure. That pressure is not there. Because that pressure is not there, this much balloon will again collapse and that much air will come out. So this is basically what is happening in the lung. Okay. So in the lung, in each alveoli, there is already some air existing. It is not flat. It is not deflated. It is inflated. But now when the pressure changes occur, air rushes in. When air rushes in, air eventually comes and fills up each and every alveoli. So each and every alveoli will become bigger in size than what was there before inspiration. So each alveoli will become bigger like this. Because each alveoli will become bigger, air which has entered inside, there will be plenty of air in it. And this air is atmospheric air. And this side also has to go up and this side also has to go up. Now what we are watching is bilateral equal rise of chest. So here we saw from the lateral view. So we only saw one. Now when we are seeing like this, we look at the person from top. What we have to see is that the left side of the chest and the right side of the chest, both are going up equally. Then we say there is bilateral equal chest rise. Bilateral equal chest rise means the air filled in the right lung also and the air filled in the left lung also. And that's why this came up and this came up. So that is what we have to look for, bilateral equal chest rise. That is very important. And when we are looking at the bilateral equal chest rise, we might not be able to appreciate. And therefore, you have to take out clothes of the patient before you examine the patient. Okay. Now, suppose we are not able to appreciate it. Then what we have to do is we have to put the thumbs next to the sternum and the rest of the hand. So I'm showing you one side. This is next to the sternum and this hand, and both sides we have to do. And we have to see whether both the thumbs move away equally. And both the thumbs move away equally means both the chest, left and the right chest is moving. That's why the thumb is moving away equally. So one is on inspection and second is on palpation. So to confirm whatever you're seeing on inspection, you have to confirm on palpation that there is bilateral chest rise. And whether it's equal or not, we can't see on. Therefore, if the thumbs move equally away, it is bilateral equal chest rise. If now this thumb does not move, but this thumb moves, that means this side lung air entry is occurring. In this side lung air entry is not occurring. Okay, still we can be wrong. We might have not placed the thumb properly or the chest would not rise. So once we are sure, or we are, sorry, not the word sure, we are doubtful that this lung is not moving properly or is moving less than this lung.
जस्ट वेट, कुछ प्रॉब्लम हुआ होगा इंजीनियर सर का नेट का. ओके
ओके मैम.
जस्ट वेट, आई कॉल सर. ओके
ओके मैम.
Okay, I've got my internet back, so you'll be able to hear me. I'm just waiting to get the sharing thing.
सर, आई मेड यू होस्ट.
Okay. किधर गया sharing का? Okay, so we were talking. Sorry for the disturbance. I lost my internet connection. I hope you can hear me.
Yes,
Yes, sir.
sir.
Yes, sir.
Yes, sir.
Okay, so we saw that by inspection, I don't know how much you missed. By inspection, we can see the chest is rising equally on both sides. If it is not rising equally, then we know one side is affected. For example, this side. Then when we do palpation, we are going to place the thumbs here, and we see that each thumb moves equally away. When we examine the person, both sides it moves equally away. But since this is the affected side, this thumb will remain here, whereas this thumb will go till here. So that means air is entering properly in this lung, air is not entering properly in this lung. Okay, now we have to 100 out of 100 times confirm because we might be making a mistake. So what we do is now we are going to auscultate. When we auscultate, you always auscultate the normal side first. So upper lobe of the normal side, and you compare it with the upper lobe of the side which is affected. And so you'll find that the air entry is less on this side because this is the normal air entry. So this you can make out as a less air entry. This is upper lobe. Then if the person is lying, then from the sides you're going to do the lower lobe and you find air entry proper, and this side lower lobe air entry is decreased. So that is how we confirm that the air entry is decreased. First by inspection, then confirm it by palpation, and last we confirm it by auscultation. Okay, so that is what you have to remember clinically. Rest of the stuff is for your understanding. You can forget about it. But what we are interested in when we see the patient, what we should understand. And that's why this is all understandable. This is muscles contract. So inhalation is an active process, whereas exhalation is a passive process. And because exhalation starts, or because the alveoli themselves have started to contract, again, there is no muscle in it, no elastic tissue. It is the elasticity of the alveoli. We use a word. We are using a word. It's just like saying the elasticity of the balloon. There is no elastic tissue in the balloon, but we say elasticity of the balloon. That's why elasticity of the alveoli, which has got stretched due to air filling it, it will again become less. Air will come out, and all the muscles will therefore relax. And then again, the next cycle will start. So that is how we breathe in. More of it will be done in physiology. You can understand it. This example I gave you, even in heart, lung is one organ which is getting blood all the time, but that blood is for its function. Pulmonary artery brings blood for function to oxygenate and take it back by the pulmonary veins. So the artery which leaves the heart is called pulmonary trunk. It is not called pulmonary artery because there is a right pulmonary artery and a left pulmonary artery. So there is nothing like a pulmonary artery. So that is called pulmonary trunk, or you can call it the common pulmonary artery. For nutrition, as far as nutrition is concerned, that is oxygen and glucose to the lung. When we break down, there is nothing like lung except there are bronchi, bronchioles, and alveoli. And therefore, the name of the artery is bronchial artery. Because lung itself is a collection of all this. Like I told you yesterday, tree word is there, but tree is only branches and leaves. So these are called bronchial arteries, and these are branches basically of thoracic aorta. There are little changes, differences, but as long as you remember that it's a branch of thoracic aorta, it is more than enough. Okay. Nerve supply of the lung, naturally, it will be from the autonomic nervous system because it is a part of it is an organ, and sympathetic will come from what is known as pulmonary plexus, whereas parasympathetic will come from vagus. Okay. Now, visceral pleura, visceral peritoneum, visceral pericardium, these, when they get stretched, when anything happens to them, no pain is felt because this nerve supply is from the autonomic nervous supply. Whereas parietal pleura, parietal pericardium, not so much, but parietal peritoneum definitely. So parietal pleura and parietal peritoneum, that is abdomen and thorax. Basically, the parietal, because it is coming in contact with the abdominal or the thoracic walls. This is the thoracic wall made up of ribs and muscles in between, okay, or the diaphragm, one of them. And therefore, this is supplied by the systemic nerve supply. Systemic nerve supply is what we can appreciate pain in it, and therefore pain can be felt if there is something, if there is stretch of parietal pleura, or if there's inflammation in parietal pleura, etc., etc., etc. But as long as visceral pleura is affected, we can feel no pain. Okay, same thing goes for peritoneum also. And then when we are doing CNS, I'll explain to you a little. So that is why, because parietal pleura is having systemic nerve supply, and in which pain can be felt, pain of pleurisy can be felt because there's a fluid collecting between the two layers of pleura, stretching the parietal pleura, and when the parietal pleura gets stretched, person can feel pain. Okay. Now we left out some slides here before we started. No, we didn't leave out, so it's all right. We are coming to this. So normal respiration is an involuntary act. Involuntary act means that we don't need, now as I was telling you, the diaphragm is a very, very, very different muscle than any other muscle. it does not need nerve supply from the systemic to contract. That means we don't tell the diaphragm you contract. Diaphragm contracts on its own. Though it is a skeletal muscle, it should be under voluntary control, but it is not under voluntary control. It is a muscle which has no insertion. It is inserted into its own tendon. It is a muscle which relaxes when an opposite muscle does not contract. So diaphragm is a very peculiar muscle. It does not follow any rules of the rest of the muscles of the body. Okay, and that's why the nerve supply to it is also not from the autonomic, not from the systemic nerve supply. It is coming automatic and it is an involuntary act. Okay, so this, because of this involuntary, respiration is done on its own. We don't have to inspire. But if we want forced inspiration or forced expiration or holding the breath, any one of the three phases, we said there are three phases of it. These can be controlled with some practice. Okay, so those people who are doing yoga, they can do forced inspiration. They can also do forced expiration. People who do yoga can forcibly expire, so forcibly expire air out of the lungs that it actually makes a sound. That much they can do. And holding the breath, of course, this is also common when people are swimming underwater. When we are swimming underwater, we are holding the breath and swimming. We are neither inspiring nor expiring. So all these can be done with some conscious control over it. Because what happens is, simple, trying to make you understand this is, I can give you a very simple example, that the heart beats because of the SA node. Rate. I'm talking about rate. Okay. Others Hindi movies, they say that the heart is beating because he has seen her for the first time, and now it is beating because of her. So till that time, for 20 years of the life, God knows what happened. But abhi dil ki धड़कन तुझे देख के ही चालू होती है ऐसे. Anyway, दिल की धड़कन हमेशा SA node से ही start होता है, and this SA node is passing the impulse, as you know very well, to the whole heart, and the whole heart is getting stimulated, contracting, and the heart is beating. So it is the SA node which is doing it independently, which I told you, SA node is a modified myocardium. It is not nerve tissue. This is modified myocardium. It is a muscle which is modified and it is conducting the impulse through the heart. Please remember, this is not nerve. This is not nervous system. God was so intelligent that he made the heart away from the nervous system. So the heart has nothing to do with the nervous system. Even if the brain is dead, if the person is in coma, the heart beats on its own. So it is not under nervous system control at all. It is having its own, so to say, nervous system, which is the wrong word to use. It is controlled by its own muscle, which has modified and become the conducting system of the heart, including the SAAV and the bundle of his and Purkinje fibers and everything. But this SA node, which is the pacemaker of the heart, that means this one decides at what rate the heart will beat. This can be affected by the autonomic nervous system. That means sympathetic can come and act on this SA node and tell the SA node to increase its rate. And when the rate has been increased by the sympathetic, the parasympathetic will, later on when that need is over, parasympathetic will come and tell this SA node, go back to your normal rhythm. Okay, so always they say classically the boy is waiting for the girl, and he knows the girl will come. When she will come, he will talk to her, and he's waiting with the rose in the hand. When she comes, suddenly he's not able to talk to her. So to help that person talk to that girl, his sympathetic system becomes active and his heart rate increases, trying to help him that you talk now. But he's not able to talk to her for some reason. So there's no need to increase the activity heart rate, and therefore the parasympathetic will come and decrease the heart rate back to SA, and SA will continue its own things. So the SA can be acted upon by the autonomic nervous system. Now here, because it's an organ, autonomic nervous system will act upon it. But nervous system is not directly responsible for heart. Please understand that. It can increase or decrease the heart rate, but it cannot start or continue the heart rate. Okay. If that was there, we wouldn't have anything called gradient tachycardia because we would be able to control it. Similarly, absolutely similarly, the lung also is not directly under the control, and therefore this can be changed by the systemic coming and increasing, decreasing, or even breath holding, which is common when person is swimming underwater. Okay. These are the normal respiratory rates in infants, children, and neonates. Okay. Even if you remember adults, it is more than enough. Now, what can increase breathing or decrease breathing for that matter? Both. One is physiological. Exercise can increase. It's physiological. It's not a disease. Or it can be a simple disease, like let's take fever, or a very bad disease like shock, or conditions that affect the lung. That means whenever we want to know any disease anywhere, you divide it into two always, or sometimes three. One is diseases that are affecting that system. Another is general diseases, or general, the whole body, not that particular system, but the whole body. And this I will keep for afterwards. For example, supposing respiratory system is not working properly, breathing is not proper, either increased or decreased, then the problem could be in the lungs, pneumonia, bronchitis, COVID, anything. Or it could be a general thing. So this is first example that we took was local, that particular system is affected. Or it can be general, correct? So acidosis, okay, metabolic disorders, brain damage, any of these can give rise to change in breathing pattern. But where is that problem? The problem is not in the respiratory system. The problem is somewhere else in the body, and that we call general. Okay. Third is drugs. Drugs. Sometimes along with drugs, everything that is associated with addiction. So drugs, alcohol, etc. Okay. So drugs. With everything being normal, locally everything being normal, generally everything being normal, a drug can either increase or decrease that problem. And therefore, usually classification of any disease is very simple. Think of local causes, think of general causes, and think of drugs which are altering it. See here now, factors that can decrease breathing. We saw now the condition which will affect the brain, that is general conditions. Nothing to do with respiratory system. The lungs, bronchitis, trachea, everything is perfectly normal, but somebody which controls this is having a problem. Or certain drugs, so they can decrease like that. So every time any disease is there, always think if this is the problem, then either the cause is lying in that local in that system, or the cause is lying in general somewhere else, or it could be drugs. Okay, now we are skipping this thing for the time being. Skipping it for time being. Time being is just now only, and then we'll come back to it. This is pleura. Okay, now the pleura is a serous membrane or a synovial membrane, both in between the joints. I will call this a synovial membrane. Today we are calling it a serous membrane. So it is a membrane which is lined either by serous cells or by synovial cells, and it is a closed sac. Remember, it is a closed one. It is not open. It is closed. Getting tired of this. This is closed, and it secretes a fluid which is called synovial fluid or serous fluid, and that fluid is inside that closed sac, and that fluid is manufactured by the same and is excreted by the same, secreted and excreted by the same serous cells. Okay, so if these serous in this serous sac, if these serous cells are manufacturing the serous fluid, which is say 10 ml, then when it becomes 11 ml, these cells will only excrete out the extra 1 ml. So they are only responsible for secreting as well as excreting the fluid. So whatever fluid is used up is thrown out and fresh fluid is replaced. Okay, so these are flattened epithelial cells. Basement membrane, word you forget. Now this you have to remember is one closed sac. Okay, this one closed sac will become 2 layers, and we will see how that is happening, and then we will come back to this. So we'll start with this. This is one layered serous sac, one layer serous sac containing or formed by serous membrane, which is cells are there which are secreting a fluid called serous fluid, which is there black in color. So this is serous fluid which is there inside the serous sac. This serous sac is closed. It is a closed sac. There is no hole in it, because the moment there is a hole, all this black fluid will come out. So you have to remember that all pleura, pericardium, peritoneum, synovial sacs, serous sacs are all closed sacs. They have no hole. If there is a hole, then the fluid will come out. Okay. Before we go ahead, first let's do pathology, then we'll do normal. So back to what I was telling you, that this sac itself is going to secrete the fluid and itself is going to absorb the fluid. Okay. Now, if for some reason it will not be able to absorb the fluid, then the fluid will collect there. Classical example of this is tunica vaginalis hydrocele. The fluid is collecting inside, and that is why that is known as hydrocele. Hydro meaning water, cele means fluid inside a cavity. Or this fluid is being manufactured more. For example, in wet pleurisy, because of the inflammation of the pleura, where am I drawing? Because of the inflammation of the pleura, there is more transudate and exudate, and more pleural liquid is formed, and that's why that fluid is collecting inside the sac. Okay, but it has to collect inside the sac. There has to be no hole. What I'm trying to tell you is that there will be no hole. If there is a hole, the fluid will come out. So the fluid can become extra in that sac either if it is not excreted out or if more is manufactured. So normally neither of them will happen. The correct amount is manufactured and the correct amount is excreted, because this fluid is used for whatever purpose it is there. It is used, it becomes old or it becomes stale, and then it is thrown out and new fluid is made. Okay, now this is closed sac. It is containing either lined by serous or synovial membrane, and therefore it has either serous or synovial fluid inside. Now this is called a bursa. This is called a bursa, a sac lined one layer, remember, sac lined either by synovial or serous membrane containing that fluid. This is called a bursa. Literally a bursa in Greek means a purse, right? So in the good old days, how did this word come is, this is a purse. Now when I say purse, don't think of males and females, because female purses can be any size, shape, color, etc., and it can contain anything in it. Of course, the male purses usually have money and some books and some notes in it. Other than that, it doesn't have many things because the size is small. Now when this name came, in those days, we did not have notes. There were only gold, silver, copper coins were there. Right? And to carry these coins, they needed a bag like this. And this bag to hold those coins was made up of leather. It was a leather bag, not a cloth bag, there's a tear. It was a leather bag, and there were no zips or buttons. So then a part of the leather strip would pass through this like this. And when we pull this, this would close. And when we make it loose, it will open. So it is this, what we call nowadays pouch. Okay. So it used to be a leather pouch in which coins used to be kept, and that resembled no hole in it. And that resembled this. And therefore the name given to it is bursa. Okay, so bursa, all the time that we are going to talk about, I'm going to use the example of a balloon filled with water. So it's a balloon filled with water, one balloon, one layer, and there is water. Of course, water is not to its maximum capacity, little water is there. Okay, so this is a balloon filled with whatever slides I'm skipping, we'll do it again afterwards. This is a balloon, you can make out its slide here. This balloon is filled with water, right? But not fully filled with water, but partly filled with water. And now I'm able to put my fist inside this balloon filled with water. So what has happened is this balloon, blue color, is still here, blue color, blue color, blue color, and it continues. It's still one cavity, right? It is still, there is no hole in it, but for all practical purposes, if I see from here or from this side, it looks like my fist is inside the balloon filled with water. It is not. My fist has not gone inside the balloon filled with water. It is not broken, because the moment it breaks, if I put my fist inside, all the water will come out, this balloon will become flat. So this hand has gone inside, fist has gone inside. This process of an organ going inside a bursa is known as invagination. This is known as invagination. So when this fist is going in, it is becoming invagination. Now, wrongly, we are using two different words. The part of the balloon which is covering the fist, red in color, I'm saying this part of the balloon is covering the fist, is touching the fist, whereas the rest of the balloon is not touching the fist. Right? So the rest of the balloon which is not touching the fist, I'm going to call parietal, and the part of the balloon which is touching the fist, I'm going to call visceral. Now the word visceral means organ, you know that very well, but the word parietal, parietes means wall. I think I told you when we were doing pericardium, this means wall. And I told you there is no wall around the heart, then how can we have a wall called parietal pericardium? So parietes means wall. So the part of the balloon which is in contact with the thoracic cavity or is in contact with the abdominal cavity, that part of the balloon is known as parietal pleura or parietal peritoneum. And the part of the balloon which is in contact with this is known as viscera. If I take out my hand from here, then this balloon will again look like a balloon filled with water. See, this balloon will again look like a balloon filled with water. Okay, so I have made no holes in it. I have not broken it. It is still one sac and it is still containing the water in it. Okay, so an organ only invaginates into it. He maintains it as it is. Why this came up? So this is the black color is the pleural fluid, correct? The blue color is the sac or the cavity. Now we are calling this the pleural sac, and this is the pleural cavity containing the pleural fluid. Blue color balloon containing black color water. This is the lung which is growing, right? And this lung is going to grow or invaginate into this, and it is also going to increase in size. Okay, both the things are going to happen together. So this is lung is invaginated into this, and the lung is growing. Okay, so we see this blue line is now gone onto this growing lung bud, and it has come back like this. Now this red lung has grown to its maximum. So the lung is like this. The blue which is covering the lung again at the hilus turns and becomes blue, which is covering the thoracic cavity. So now you can make out that the pleural cavity or the pleural cavity containing the pleural fluid, which is black in color, is minimized. It is visceral and parietal are next to each other. But again, as far as understanding this is concerned, it is correct. But in reality, the visceral pleura is extending beyond the parietal pleura is extending beyond the visceral pleura. Okay, that is what we have seen in all three dimensions. It is more, but forget that part and we stick to what we are learning now. We are learning different things. So we are saying this is the parietal layer and this is the visceral layer. But when we saw, it was not 2 layers, it was 1 layer. It is 1 layer, it is 1 layer, it is still 1 layer. That's why the black right pleural fluid is in it. If it ever bursts, or if this is 2 different layers, if we say that this is visceral ending here and this is parietal beginning here, these two are not same continuation, the fluid would have come out from here. So this is what I'm trying to make you understand, that it is 1 layer, right? It has folded itself, and because it has folded itself, one is attached to the wall, one is attached to the organ. We have given it 2 different names, but it is one sac. Okay, see more examples so you can understand. This is a fluid-filled balloon. This fist is going inside, so that is called invagination. And when this is the whole process of invagination, now whatever balloon was or is around the fist is the same balloon that is here. It is not different. It is the same balloon. Otherwise, the balloon would have burst and water would have come out. So, but the part of the balloon which is around the fist, we are going to give it a different name, and the part of the balloon which is not around the fist, anywhere else, we are giving it a different name. That's all. So when we talk, we say that the visceral pleura becomes continuous with the parietal pleura. So we are saying this is parietal pleura, this is visceral pleura, and these two become continuous with each other, which is wrong because they are already continuous. So these two become continuous with each other at the hilus of the lung. At the hilus of the lung. Similarly, here also we'll say this is the visceral, this is parietal pleura, this is visceral pleura. So visceral pleura becomes continuous with parietal pleura at the hilus of the lung. So that is a method of talking because we have given it 2 different names, whereas in reality it is one only. Please remember that. Okay, so all the cavity, all the serous membranes containing the serous fluid, that is pericardium, pleura, and the peritoneum, are like this only. Okay, let's see. There's one more example. Remember, this is happening in fetal life. So while the heart is growing, the pericardial cavity comes first. Pericardial cavity is already existing. Okay, and the heart is going to go in it and grow, go and grow. So the pericardial cavity has to be bigger than the present heart because it has to accommodate the whole of the heart. So this is the pericardial cavity still around. Still around, and this is the heart which is growing. This is the heart which has grown totally, and it looks like the heart is inside the pericardial cavity. It is not, because you can see here the parietal layer is becoming continuous with the visceral layer. This is visceral layer going around. For our understanding or our talk, in reality, it is one. So this is the balloon, this is the fist going inside, this is the real pericardium, and this is the heart going inside. Okay, so this part, this one is the visceral pericardium, correct? This, which is on the outer side, this is the parietal pericardium. So this is parietal pericardium of the balloon. The black one is the visceral pericardium of the balloon, where the arrow has gone blue in between. That is the pericardial cavity. This is the pericardial cavity. Okay, here because it is balloon filled with air, this is air space. Otherwise, it will be pericardial cavity. So in the heart also, it is same thing. So that's how this pericardial fluid can remain here. Okay, now add to this one simple thing. There is a wall around this. As far as heart is concerned, there is a wall here, and this wall is called fibrous pericardium. The wall is called fibrous pericardium. So see here, this inside one near the thumb, and here this is the visceral pericardium, which is in contact. This outer one, this is the parietal pericardium, correct? And this is the pericardial cavity, blue in color, containing pericardial fluid. There is another pericardium here, right? Or what we call wall of the heart, and that is known as fibrous pericardium. This is fibrous pericardium. If we go and look at the example from here, we cut the heart and see this outside thing is fibrous pericardium. This is the visceral pericardium. This is the parietal pericardium. This one is the parietal pericardium, and this is the fibrous pericardium. Okay, and that is the wall. That is the wall. The fibrous pericardium is like the thoracic wall or the abdominal wall as far as pleura and peritoneum are concerned. So the parietal pericardium has to be in contact with the wall so that it gets support. If this is parietal pericardium, pleura, whatever you want to say, and this is the wall, this has to be in contact with it, so it is supporting it. It cannot be like this, otherwise it will keep falling down. Okay, so therefore even the pleura is attached to the thoracic wall and the thorax size increases, so this pleura is getting pulled, and therefore there will be a difference between the visceral pleura and the parietal pleura, and that is what is going to be the whole physiology of breathing. So it has to be attached to the abdominal wall, the thoracic wall, and therefore here, if this is the wall of the heart, it has to be attached to it. So that is what I'm trying to show here, that there is no space between them. Don't expect pericardial space, pericardial fluid to be here, because this is not the two layers. The two layers are the visceral and the parietal. So these are the two layers. There is no space here. This I've drawn just to show you the difference. In reality, it is like this. The fibrous pericardium and the parietal pericardium are, so to say, fused together. There can be no space. There is no space. There is no potential space also. Right? We'll see what is the meaning of potential space when we do breathe. Okay, now I'm leaving heart there at this slide, and we'll come back to heart afterwards. Now what happens is, during embryonic life, just two lines. This is how we look like. Either we are seeing at the mesoderm or the ectoderm, right? So this is the outer is the ectoderm, middle is the mesoderm, and innermost is the endoderm. So this red line either is showing ectoderm or endoderm, and I'm basically interested in the mesoderm. So in the mesoderm, what happens is mesoderm has grown everywhere here, and then in the mesoderm, a cavity appears, and this cavity is horseshoe-shaped cavity. Okay, this where I've written septum transversum. You can forget the words. I'm talking about the words just to tell you for 1 second. Here the mesoderm is not grown. Here there is no mesoderm, and here there is no cavity. Now this horseshoe-shaped cavity which is there, this is known as the coelomic cavity, and then partitions occur in this cavity, and these partitions will make this. No, I should have taken red color, or we'll take a different color only. So here there is a partition which will occur eventually, and this will separate out. This will separate out. Similarly, this side will separate out. This is going to become the future pericardial cavity. This will become one pleural cavity where one lung will invaginate. This is the other pleural cavity, right? And then this will fold like this. This thing is going to fold like this, and therefore the left side and the right side peritoneal cavity will fuse and become one big peritoneum. Okay. We are not doing peritoneum right now because that is very confusing. But pleural cavities, we saw there are two of them, and we saw that there is one pericardial cavity formed. Now this septum transversum which is there. So coming when what happens is, this is going to be the head fold. There's going to be one tail fold. So the septum transversum is coming somewhere towards the middle of the future embryo. You see, when chapati is made, right? First little chapati is rolled, then we put ghee in it, or we can put aloo paratha in it. For aloo paratha, then we fold this, then we fold this like this, this like this, this like this, and then we again roll out the chapati. So similarly, in the embryo, there's going to be head fold, tail fold, and two lateral folds. So what I want you to understand is septum transversum, which was here at the top near the head end, has now come somewhere in the middle of the body. Okay, approximately in the middle of the body. Because still body is not even formed. So body is the wrong word to use, but then some understanding. So this is septum transversum. This septum transversum, which is there somewhere in the middle of the body, is going to change to become the central tendon of diaphragm. Most of it is going to become the central tendon of diaphragm. It will have a prolongation cranially or headwards, and that is called fibrous pericardium. And it'll have an extension which is going downwards or towards the abdomen, and that will go and cover the liver, and that is known as Gleason's capsule of the liver. So the liver is attached to the diaphragm because both of them took origin from the same place. Now imagine liver is going to go in this blue thing. Huh? So the liver is attached to the central tendon of the diaphragm because when it grows, it isn't going to come in contact with this only. It cannot grow out of this blue thing, and this blue thing is covering the liver, and that is known as Gleason's capsule. But this blue thing is not covering here because this blue Gleason's capsule came out from this septum transversum. So it is directly in contact with the diaphragm. So the liver cannot be dissected out. Cannot dissect out the liver because the liver is attached to the central tendon of the diaphragm, and therefore we have to cut here. And when we cut here and then cut the liver like this and take it out, there is a bare area on the liver which is not covered by peritoneum. This is that. Anyway, even if you forget this, it doesn't matter. Here, what is happening is central tendon of the diaphragm itself has given out a prolongation, which is going all the way into the thorax, all the way till the deep fascia of the neck. That means it is passing through the whole length of the thorax till the deep fascia of the neck. And this extension is called fibrous pericardium. What I'm showing you is a section. So please understand, in a way I'm telling you, this central tendon of diaphragm is like the base or the ground of a well. And the wall of the well is the fibrous pericardium. And then in this well, now in this well, there is the heart covered by this. I'm keeping a lot of space, but a lot of space won't be there. This is the heart covered by its two pericardiums. So this is the visceral pericardium, and this is the parietal pericardium. Now the parietal pericardium is touching the wall of the well, and therefore it is called parietal. And that wall of the well will be replaced with wall of the fibrous pericardium. And that's why that is called parietal pericardium. Okay. That done. Now we'll go back to what we had skipped. We were at this diagram, and then we started going ahead. So let's go to this diagram. This is, of course, embryology. This is GI tract being formed. GI tract is there from the mouth to the anal opening, and from the anterior part of the GI tract tube, upper end also. That is, let's take future esophagus. Somewhere at the level of the future esophagus, one bud grows out. This is a lateral view. The bud is going anteriorly. Okay, so this bud then prolongs. When it prolongs, it goes down inferiorly, downwards, right? And eventually, this gets separated from this GI tract. This closes, and this remains open. Please see, I've drawn an opening. Okay, and this closes. This is the future trachea. This is the future trachea. This esophagus is again closed, whereas the tracheal opening above is open, because till now no nose is there, no pharynx is there. When nose and pharynx will come, it will get attached to this. So this cannot be a closed part. This has to be an open part. Okay. So eventually what will happen is this will become esophagus. This will become the trachea. Now, if this will persist, then you have heard of a congenital abnormality called tracheoesophageal canal or tracheoesophageal continuation. Okay, mostly it does not happen. Esophagus closes and the trachea is like this. The lower end of, now remember, this is posterior, this is anterior. I'll show you, or we'll go and see the diagram. This is posteriorly esophagus, this is anteriorly the tracheal bud, and the tracheal bud inferiorly diverts into two or bifurcates into two, and these are now called lung buds. Each lung bud will become a lung, but it will go into the pleural cavity, invaginate into the pleural cavity, and become a lung like this. So this tracheal bud is becoming, now it is branching into something, wrong words I'm using. It is branching into principal bronchus. Principal bronchus is going into the secondary bronchus. Secondary bronchus will still branch, become tertiary bronchus. They will still branch. Bronchioles, they will still branch, and eventually at the end of it, there will be alveoli, and that is the lung. Okay, so this is how it is going to happen. Back to what we were drawing. That is that much only. So these are the lung buds. From the lung buds, I've taken up the diagram into this and shown you how it grows into this. And at the same time, if you see the GI tract, which is behind, is now grown into esophagus and this dilated thing known as stomach. That's how the relation of the esophagus and the trachea is anterior posterior. This is again showing esophagus behind, trachea in front. These are the two secondary bronchi. These are the three secondary bronchi on the right side. Again, they will branch and branch and branch and branch, and the whole tree will be formed. So instead of thinking the tree is directly there, we are forming the tree actually because this is embryological life. So this is the wrong thing. It is not that the tree is existing from first lung. This is only to show invagination. This is to show exactly invagination as well as the branching. This is just to show invagination. This is to explain to you serous and fibrous pericardium, from where the fibrous pericardium came. Now back to heart. So this is pericardial. This is normal pericardial fluid. This is abnormal collection of pericardial fluid, which is known as pericardial effusion or cardiac tamponade. Right? This cannot go up like this. This is a little wrong diagram. It will not go up. It will only remain like this. Let's see in different diagrams. So it cannot go up. Remember that, because the great vessels are there. So the fluid is collecting here between the two layers. This is the visceral layer and this is the parietal layer. This was originally the parietal layer and this is still the parietal layer. So sorry, I'm making mistakes in telling you. We'll start again. This is the parietal layer originally and today and now. Okay, this was originally black one. This was originally the visceral layer. Visceral. Okay, now what is happening is there is fluid collecting. When the fluid collects between the two, we would expect the parietal layer to extend like this. Because whenever there's a swelling, this is called swelling. Okay, visceral layer remaining as it is, the parietal layer has to increase like this and go away. Now this parietal, I'm taking out visceral layer for time being. This parietal layer cannot move because there is a fibrous pericardium here. Because of this fibrous pericardium, this parietal layer, even if it wants to move, it cannot move because it is in contact with it. So what happens? The pressure goes backwards. So this red color thing is not able to expand. Please understand this. This red color thing is not able to expand because there's a fibrous pericardium sitting there, which will prevent its expansion. So the fluid which has filled up here is going to cause a backward pressure. Even if I take out the word backward because it's wrong for you to understand, it is causing a pressure on the visceral pericardium. But visceral pericardium is already in contact with the heart. So the heart size is becoming small. See, the heart size which was here, the heart, including the visceral pericardium, has moved here. So heart has to become smaller. If the heart becomes smaller, naturally the heart cannot beat properly. Okay, that is the main thing you have to understand. Because if you don't understand this, you think when pericardial fluid will contain increase in size, pericardial effusion, it will become big. It is not going to become big. It is only going to press on the heart and make the heart size small. See, all the arrows are showing that it is going to the heart. Plus, these are all sections. In reality, it is three-dimensional heart. That means from the interior also it is pressing the heart backwards. From behind it is pressing the heart forwards. From the left side it is pressing the heart inwards. Right side it is pressing inwards. From below it is pressing upwards. From all sides except superior. See, these are all correct diagrams. Superiorly, it cannot go because these three great vessels, the superior vena cava, the aorta, and the pulmonary trunk, these three vessels, this is where pericardium is attached. So this cannot go upwards and it is getting pressed from all sides except from superior. But let's forget except and say that it is getting pressed from all sides. So the heart size is becoming small. Please notice that in all diagrams, the size of the heart is becoming smaller. Okay, pressure is coming from all the sides and making the heart smaller. If the heart is smaller and the heart is hanging from these three great vessels, you saw here, it is not attached above. So literally, if I take one line like this of the three great vessels, and this is where the heart is attached below this, the heart is swinging. The heart is swinging in the free fluid. The heart is swinging because it is three-dimensional. Okay, because the heart is swinging, at one time the heart is able to expand properly. At another time, the heart is not able to expand because the pressure is coming on it. Again, alternately, when the heart will again expand, heart will not be able to expand. So when we take the ECG will show the electrical, what do you call it? The electrical activity. This is called amplitude on the ECG, the voltage. won't show proper height. Again proper height, again not proper height. It is not abnormal. The height is not proper, voltage is not proper, that is amplitude is not proper. And this type of an ECG is known as electrical alternance. Please don't confuse this with pulsus alternance. This is on ECG and this is called electrical alternance. What is happening to the ECG here is irrespective. Whether this ECG is normal, abnormal, I'm not talking about that. I'm talking about this amplitude or the height of this ECG alternately being tall and alternately being short. Okay, this is called electrical alternance, and this is a characteristic of ECG of pericardial effusion or cardiac tamponade. So this is an example of cardiac tamponade where blood has collected. We have put the person in an erect posture. Erect means standing or sitting as far as thorax is concerned. So all the fluid will come down, and then we can put a needle here and take out this fluid, and that is called cardiocentesis. Okay, of course, it's not easy as I'm telling. We need USG to see where we are putting the needle. So that is pleura and pericardium done together, and this is again showing the parietal pericardium and the visceral pericardium as being in different places. Here also we saw, here also we saw. Now this is pleura, this is where we had stopped. We had said it has two layers, visceral and parietal. The two surfaces of the pleura are close contact with each other during normal health, kept apart only by a thin film of serous fluid, which allows frictionless movement. So now why are we putting this bursa anywhere? I hope I'm not exceeding that 9 to 11, that's not at 11. Wherever we saw that bursa, the main reason for this bursa to be put anywhere, it is put between two bones to form a joint known as synovial joint. It can be put between a bone and a tendon so that it doesn't rub. See, all these tendons are going from here. There are carpal bones below. Every time we do this, the tendons will scrape on the carpal bones. So there is a big bursa put there between the tendons and the carpal bones. So wherever this bursa is put, it is to prevent or decrease friction. The function of it is to prevent or decrease friction. Okay. And so in the lung, because the lung is going to expand and contract with every breath, there is movement. If there is movement, naturally there is going to be friction. So if there was no pleura, then the lung would rub on the thoracic wall, which is made up of ribs and muscles. It will rub on that all the time, and by the time we are 3 years, it will rub and burst. To prevent this, so that it lasts a lifetime without bursting, the god has put one pleura in between. And the pleura has got two layers, one naturally on the wall, one naturally on the lung, so that they don't rub against each other. And there is a thin film of pleural fluid, which is there in between the two, so that the movement is frictionless. If there is inflammation of the pleura, naturally there will be a fluid coming out due to, depending on whether it is a transudate or an exudate, and that fluid is known as pleural fluid, and that is known as pleurisy. And we call that wet pleurisy because there can be an inflammation without the fluid, and then that is called dry pleurisy. So the visceral pleura is firmly attached to the, this I've written once, that applies to all organs. Visceral pleura is always firmly attached to the lungs, is reflected back at the hilum, which I showed you to become the parietal pleura, or this way to that way, which is attached to the wall. Parietal pleura is attached to the inside part of the wall of the cavity. So it is attached to the inside part of the thoracic cavity and inside part of the abdominal cavity and on the inside wall of the fibrous pericardium. If fibrous pericardium was given a different name, it would have been more simple. Okay, the space between the two pleura is called pleural cavity and is a potential space containing only serous fluid. Now, what is the meaning of the word potential? Why did I write it unnecessarily? Potential space means it is a space, but it is not there. Very simple. Simplest terms, high be, nahi bhi hai. Okay, that is what it is in very simple terms. So now I'm trying to show you, this is the pocket, right? So if, when I do this, there is no space between the shirt and the pocket. When I put my hand, now you can see, where did I disappear? Now if I put my hand like this, you can see there is a space, my hand has gone in. But when I take out this and do this, then there is no space. So there is no space, there is space. High be, nahi be. That is very simple in Hindi. So potential space is something which is there and not there. So as long as normal is concerned, it is not there. This is the parietal and visceral pleura sticking to each other, and there's little pleural fluid in between. Okay, that is normal. So no space. But abnormally, because this can collect, blood can collect here, pleural fluid can collect here, Cox ka pus can collect here, caseous material, right? Fluid can collect abnormally. Right? Normally, it doesn't collect. So these type of spaces are called potential spaces. Means normally there is nothing. Abnormally, it can be there. But it is not that afterwards the space came. Space is existing, but it can be there. So when a person sings very nicely on the college day, we say that this person has got potential to become a good singer. But that doesn't mean that they will go into the movies and start singing. They will continue to be doctors and continue to treat patients. So there is a potential, but it does not happen always. Similarly, here also, this is a potential space, and that applies for everything. Pleura, pericardium, very good. Okay, with that much done, let's go ahead and see what else we have. I think that are the last two slides. So in the diaphragm, there are three openings. Okay, because whatever has to go from the thoracic cavity into the abdominal cavity, or from the abdominal cavity into the thoracic cavity, has to go through the diaphragm. And diaphragm is going to contract every time we have to breathe. That means whatever is passing through it will get squeezed. And if there is blood in it, for example, that blood will not flow properly. So therefore, the aorta has an opening for it in the diaphragm right from when diaphragm is formed. I've shown you that opening in the diaphragm many times and told you that the thoracic aorta passes through it. So this is the opening for the thoracic or the thoracic abdomen, thoracic aorta to become abdominal aorta. That opening is already existing from first, right? Right from the time diaphragm was formed. Now, there is another big vessel which is known as inferior vena cava, which has to go from down to the thorax and pass through the diaphragm. So that is containing blood. Every time we breathe, when the diaphragm contracts, the blood in it will get obstructed and will not go up. Right? This God also did very nicely, and he saw to it that this will not happen. And the opening for the inferior vena cava lies in the central tendon of the diaphragm. Tendon cannot contract, So the blood in the inferior vena cava is never obstructed. The blood in the inferior vena cava freely flows from the abdomen into the thoracic cavity. Okay, because it is lying in the central tendon. Tendon cannot contract, muscle can contract. Now, last thing is the esophagus. So this is the esophagus which is passing through the diaphragm. There is a hole in the muscular part of the diaphragm and it is passing through it. Where it is passing through the muscular part of the diaphragm, there it gets constricted because it's muscle. And when the diaphragm contracts every time we breathe, it is going to cause pressure on it and it is going to constrict. So this is the last constriction of the esophagus. So esophagus is constricted at. We saw that the pelvic junction is a constriction. That time I told you this is the laryngopharynx. From laryngopharynx, the first part of the esophagus which forms is constricted exactly same as pelvic junction. First constriction in the esophagus, last constriction in the esophagus when it passes through the diaphragm. Two more constrictions are there in the esophagus. One is when the arch of aorta crosses it. And another is when the left bronchus crosses it. Okay, so this is aorta A, this is bronchus B, and this is diaphragm D. Where did C go? Don't ask me. And one is at the beginning. So these are constrictions. So this is the C. C stands for constrictions. So the constrictions in the esophagus are where it begins. Always, it's same thing in ureter. And when the arch of aorta crosses it, when the left bronchus crosses, and when it passes through the diaphragm. Okay. Now, because this esophagus passes through the diaphragm and we have not yet done deglutination or pharynx larynx, when this will pass through this, if we are breathing, then this will contract. If this will contract, food cannot go from the esophagus into the stomach, right? So there is no real sphincter. You remember the word sphincter? Sphincter is circular muscle fibers which can contract. And we have seen that there is sphincter at the precapillary arteriole, right? And we say there is a cardiac sphincter here at the lower end of the esophagus or at the upper end of the stomach where the esophagus joins. There is no anatomical sphincter there. There is no anatomical sphincter there. Whereas at the pyloric end, there is a sure 100% big, thick pyloric sphincter. And this pyloric sphincter closes, contracts, and it closes, and therefore food remains inside the stomach for 2 hours, 3 hours, etc., depending on how much food is eaten and all that. And when this pyloric sphincter will relax, then only food will go from the stomach into the duodenum. Food does not go directly from the esophagus into the stomach into the duodenum. Food remains in the stomach. That's why we say stomach is a reservoir of food. It remains there till some amount of digestion occurs and the gas acid inside mixes up with the food, kills the bacteria, blah, 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 blah. So it has to remain in the stomach for some time. That's why after eating, we say my stomach is full because it is collected in the stomach. It has not gone into the duodenum. Therefore, there is a lock here. There is a gate here, and this is called pyloric sphincter. God did not put any sphincter here. See, he's so clever. If he put a sphincter here, we eat, sphincter has to open, then food has to go in the stomach. Again, sphincter will close, next morsel we put, again sphincter has to open, again go into the stomach. Imagine by the time we finish those 3 chapatis and the rice and the sweet dish and the lassi on top of it, how many times the sphincter has to open. So God didn't put sphincter. There is no sphincter, right? It is the contraction of the diaphragm. Because the esophagus is passing through the muscular part of it, the contraction of the diaphragm acts like a sphincter at this end. So whenever we are not inspiring, there is no sphincter. And therefore, whenever we want to eat, we can't swallow. And whenever we want to swallow, sorry, I said something wrong. Whenever we want to swallow, we can't breathe. And whenever we want to breathe, we can't swallow. Okay, you can do one of the two things. Either you can swallow or you can breathe. You can't do both the things together. That is because of this. If you are swallowing, food is going to go through this. At that time, the diaphragm should not contract. The diaphragm should be relaxed. If like many of you say there is a pyloric sphincter at the lower upper end of the stomach, there is a pyloric sphincter. If it is there, then how will you explain these diseases? See, if there was a sphincter here, then whatever are the contents of the stomach would not go up because there is a sphincter here. And if they would not go up, then there will be no gastroesophageal reflux disease or disorder. This D stands for disorder or disease, find out. Huh? There would be nothing like esophagitis occurring because there would be no acid from the stomach going up. And if there's no acid from the stomach going up, there will be no esophagitis. Okay. So the very fact that these diseases present are there, or hyperacidity, again, in which the acid which is collected in the stomach, because there is no food and the acid is collected more in the stomach, it is going into the esophagus. That also called be called esophagitis. Whatever you do, what I'm trying to tell you is contents of the stomach can go back into the esophagus, tells us that there is no sphincter there. Plus, God did not put a sphincter there because every time we swallow, the sphincter has to open. So functionally, it is not supposed to be there. God in his wisdom didn't put it. It should not be there. And if it is there, then you can't explain why all these diseases occur. Okay, that is that. This is nothing to do with you. I don't know why that slide did come here. And the last slide is asking whether you have any questions. So anything you want to ask now. And I'm running through the slides fast to see if we have missed any slide in explanation. See, we forgot. Just give me 5 minutes, and this is an important topic. We have forgotten bronchopulmonary segments. Okay, so now we come to this. Whatever you're seeing, this is just give me 5 to 10 minutes, not more. What we are seeing here are the tertiary bronchi, not the bronchioles. Okay, so the trachea branches into the principal bronchus branches into secondary bronchi. So these are all, sorry, these 3 are the secondary bronchi, these 3 brown color are the secondary bronchi, and all the colored ones are tertiary bronchi. Now remember, lung is 3-dimensional, and therefore some bronchus will go up, some will go to the left, right, up, down, etc., etc. And this is how all the tertiary bronchi will look. I'm still talking about bronchi, not of bronchioles. This is the tertiary bronchi. Okay, this is an important topic and I forgot. So these are all the tertiary bronchi. Now what happens is the tertiary bronchi. No, first we start with like this. We start with this diagram. This, where am I drawing? this bronchus supplies this lung, because it should not come out the bronchus, it supplies this lung. Okay, now this secondary bronchus supplies upper lobe of this lung, whereas this bronchus supplies lower lobe of this lung. So these secondary bronchi can also be called lobar bronchi because they supply one lobe of the lung. Now, in comparison to this, let me pick up this blue color, this tertiary bronchus. This tertiary bronchus supplies this lobule of the upper lobe. This supplies lobule of that upper lobe. And supposing this is same color, will not change the color. This is also blue in color. This supplies lobule of this lower lobe. So like that, there is one more lobule here. There are so many lobules here. There are so many lobules here. Remember, we are taking a section or we are seeing the lung anterior posterior flat. In reality, lung is three-dimensional, and I'll show you more diagrams to make you understand what it is. In short, each tertiary bronchus will supply one lobule of the lung. Now we take out the word lobule of the lung and we say a part of the lung. We are going to use the word part of the lung. So one tertiary bronchus is going to supply one part of the lung. Now that part of the lung is called a BP segment or bronchopulmonary segment. So let's read here. One subdivision of the lobe of the lung. So that is denoted as lobule of the lung, separated from each other by connective tissue, septum, and it is aerated, means it gets air from its own tertiary bronchus, meaning this blue tertiary bronchus will supply its own lobule. It has nothing to do with air supply of this brown color or with this red color. This red will supply its own lobule, brown will supply its own lobule, blue will supply its own lobule. Air from here cannot come here, air from here cannot come here, air from here cannot go there. Something like airtight anastomosis. Okay, so it is aerated by its own tertiary bronchus, supplied by a branch of the pulmonary artery, and it is drained by two pulmonary veins. So each lobule of the lung is like a big unit of the lung. It is like this. It will be one lobule. It will have one branch of pulmonary artery coming to it, and two tributaries of pulmonary vein going away from it. And this part is known as a bronchopulmonary segment. The word broncho means that part of the segment of the lung which is supplied by a tertiary bronchus. So that part of the segment of the lung which is supplied by a tertiary bronchus is called a bronchopulmonary segment. And this is pyramidal in shape. Like you can see, this is triangle. Triangle is two-dimensional. Pyramid is three-dimensional with the apex always towards the hilum, because all the bronchi are branching at the hilum. So the apex of this will always be towards the hilum and the base will be towards the periphery. So these are the bases which are towards the periphery, and apex of the pyramid is always towards the hilum. So you can see here, now this is almost like two-dimensional, but if we are seeing this is whole of the costal surface and this is whole of the medial surface, because I didn't show you that also. This is whole of the costal surface. So if you have picked up this red color tertiary bronchus, this red color tertiary bronchus air will go only in this much part of the lung. And if you see from the lateral side, so to say, and if you see from the medial side, it will go only in this much part. This air cannot go into the blue part or the green part, because this red is connected to one lobule which is there here. Similarly, if we see this green will get blood, air will go in this, and air will go in this. So I hope you understand that each tertiary bronchus can supply only one part, one segment, one small tukda of the lung, of one lobe, and therefore that is called a bronchopulmonary segment. It is a new name kept for lobule of the lung. Good old days we used to call this lobule of lung. We used to call means much before me, hundreds of years back. Okay, so this is almost like a three-dimensional, but you are seeing only the lateral surface and the medial surface. Right now, this is again lateral and medial. This is showing one broncho, but the diagram colors are all wrong. This is showing one tertiary bronchus will supply. Don't do this. This is long. This is exactly all the surfaces of the lung. Right, so this is the medial surface, this is the lateral surface, right? This is the anteriorly and this is posteriorly. So all these four diagrams are showing you only one lung. These four diagrams are showing the other lung. So you can see from any direction, anterior, posterior, medial, lateral, three-dimensional, these are called bronchopulmonary segments. Okay. Now, bronchopulmonary segment is that part of the lung which is supplied by one tertiary bronchus and one pulmonary artery and two pulmonary veins. Means that anything from one bronchopulmonary segment as far as blood and air is concerned will not pass into the neighboring, because it is separated by its own connective tissue which acts like a septum. But diseases can cross this. Drugs can cross this, smoking, nicotine can cross this. So that is a very big disadvantage for us. If God had made absolutely tight compartments, then all our diseases would be restricted and it will not go anywhere else. So each segment is functionally and anatomically discrete, separate, meaning that a single segment can be removed surgically without affecting neighbors. So there it is. In the good old days, what would happen when there were no medicine, especially for diseases like TB? If there is TB in one lung, what we would do is take out the whole lung, cut off one lung and keep the person alive. And that was called pneumonectomy. Right? And this is in the very, very old zamana. Then when we came to know about the lobes, and if there is a disease in the upper lobe of this lung, then we would take out the upper lobe separately, because that upper lobe was supplied by a single secondary bronchus. So what we do is tie the secondary bronchus here and cut out the whole upper lobe. Neither the blood will come out from this part of the lobe, neither air will come out from here, because this lobe is supplied by its own secondary bronchus, by own branch of pulmonary artery and own tributaries of pulmonary vein. So you don't have to tie arteries and veins. We tie the bronchus, and along with the bronchus, whatever artery vein is there, we tie here and cut out and take out the whole lobe. And that is called lobectomy. This was still in old. Nowadays, what happens is, we know bronchopulmonary segment, that much part is supplied by a tertiary bronchus, what is called a bronchopulmonary segment, and we cut out only that much part of the lung, and that is known as a wedge dissection.
Okay, next time I'll show you what diagram means in veg. Or if you take a potato and cut it longitudinally into two and two more pieces, then there's four big pieces of potatoes which come out. That is called a veg shape. So this is called a veg resection. This veg resection is possible only because of the knowledge of bronchopulmonary segment. Also, this knowledge is used by respiratory physiotherapists. They study the lung bronchopulmonary segments in detail. So they see the X-ray, and if they know there is collection of mucus in one particular bronchopulmonary segment, they will give physiotherapy such that that bronchopulmonary segment will drain and the mucus will come out. Okay. Now I'm asking you if you have any questions, tell me. Any questions if you have, tell me. You don't have to know names of these bronchopulmonary segments. That is not concerning you. Okay. Ask me questions. What is this? Do you have any questions, or are you feeling hungry to eat before the next lecture? Nobody's answering. Okay. Chalo, so I take it for granted as usually you have no questions. And because you have no questions, we'll stop here.